this is the only study that tested the value of adjuvant immunotherapy in early TNBC. So basically, patients with triple-negative breast cancer, stage 2 or 3, that have received primary surgery upfront were randomized in a one-to-one based adjuvant chemotherapy with or without atezolizumab. The primary endpoint of the study was invasive disease-free survival. So we wanted to demonstrate that the addition of atezolizumab could improve invasive disease-free survival for those. This was an open label phase 3 trial in which patients with triple-negative breast cancer, stage 2 or 3, were randomized in a one-to-one ratio between standard adjuvant chemotherapy that included weekly paclitaxel followed by 4 cycles of dose-dense anthracycline-based chemotherapy regimen versus the same standard adjuvant chemotherapy together with 1 year of atezolizumab. Primary endpoint of the study was invasive disease-free survival. So the study was stopped at the interim analysis after 62% of the events, IDFS events occurred. This interim analysis has been requested by health authority, and this interim analysis, in this interim analysis, the futility boundary of 1 was crossed. So this is a negative study. So the addition of atezolizumab did not improve invasive disease-free survival in this patient population. So just to complete the data, I have to say that no new safety signals have been identified. And the addition of atezolizumab has not compromised the delivery of adjuvant chemotherapy. Now, I think these data are very important because they help us understand how to best give immunotherapy in TNBC. So knowing that immunotherapy works when it is given in the neoadjuvant setting, based on the Keynote 522 results, this study demonstrates for the first time that immunotherapy is not working when it is given in the adjuvant setting. So this is the first message, important message from this study. So in triple-negative breast cancer, don't give immunotherapy in the adjuvant setting. The second important message is that worldwide, especially in community hospitals, several patients with stage 2 disease are being operated upfront. So this study demonstrates that this should no longer be done. Patients with stage 2 TNBC should no longer receive primary surgery upfront. Why? Because adjuvant immunotherapy is not working, and because they have a better option. They can be treated with neoadjuvant chemotherapy and immunotherapy that provides benefit. So I think it can help change practice for those hospitals and those community centers that still practice primary surgery upfront for stage 2 disease, and make the point that this should no longer be done. So I think very important messages coming out of this study.